Today's presentation is going to be a discussion about the use of ultrasound during a global health crisis. I think everybody looking at this video is aware of the present global health crisis. The talk today is not supposed to be specific just for that, but of course, there'll be aspects of it which are certainly applicable to that. The goals of the talk today is going to be to talk about how point-of-care ultrasound can play a role in helping clinicians during this health crisis and the benefits and value that it can bring to the table. The target audience today for this course is healthcare professionals that are practicing in a setting that may be able to utilize point-of-care ultrasound, as well as clinicians in a primary care setting. The learning objectives today are to make sure that everybody seeing this video can recognize the benefits of ultrasound, including the portability aspects of it and the fact that it is a very cleanable imaging device, to discuss some of the various ultrasound imaging procedures that can be used to evaluate patients from both the acute respiratory status as well as cardiovascular conditions. And then there will be some slides at the end that are going to talk about guidelines and other references in medical community practices. So I'm Dr. Jeff Hersh. I am the Chief Medical Officer of General Electric Healthcare. The outline of the course, I'm going to start talking about the fact that ultrasound is portable. We'll speak to that a little bit and what the benefits are of that. And then I'm going to speak a little bit also about the fact that it is a imaging modality which can be cleaned and disinfected. We're then going to talk about some of the specific uses of ultrasound that may be important in any medical crisis, but also important in the present medical crisis. And that's going to include some focus on pulmonary ultrasound, cardiac ultrasound, shock in general, and then being able to utilize ultrasound for line placement. And then finally, at the end of the talk, there'll be some references with some guidelines and other community resources. So let's start talking about the portability and cleanability aspects of ultrasound. One of the important things is when you do a point-of-care ultrasound, the information, the imaging, the interpretation that you get from this is immediately available to the clinician performing the exam. It's an interactive procedure, and the clinician performing the exam sees the image and is able to interpret the image in real times. That's extremely important, and even more important because you can now do this point-of-care ultrasound as a set of serial exams. So if you're caring for a patient over a period of time, very likely that there will be clinical changes in that patient's condition. Those may be because their underlying disease progresses, but it also could be because they respond or do not respond to some therapeutic intervention. So being able to do serial exams and being able to use that to identify clinical changes is extremely important. That can be important because the clinical change could be a complication. So for example, you have a patient who may be intubated and they have a significant clinical change. You might have a suspicion that they've developed a pneumothorax, and being able to do a point-of-care ultrasound can be very useful to identify that indeed that is the case. So there are many, many examples of that. I'll speak to some a little bit later. Other aspects that are important about ultrasound is that it is a non-ionizing radiation imaging modality. And so you don't have to worry about exposure to radiation. Of course, that's not a huge concern if you have a sick patient and the benefit of even ionizing radiation outweighs the risk. But it's not an issue at all in ultrasound, since ultrasound does not utilize ionizing radiation. The other aspect that this is very important is because you can do the ultrasound right at the bedside, you don't need to transport the patient anywhere. And this is obviously beneficial for a patient who is very sick, that maybe you don't want to leave your ICU, or there's other complications or confounding factors about transporting them. But also if they have an infectious etiology, you may want to minimize transporting them throughout your healthcare facility. And being able to do the portable ultrasound right at the bedside is beneficial there. This is also extremely beneficial if you're going to utilize certain spaces for healthcare during a medical crisis that maybe you would not otherwise be utilizing. So for example, if during the crisis You might be utilizing some beds as ICU beds that you normally would not. Maybe you're using your recovery room to give you added capacity. Maybe you have a broader or a makeshift ED of some sense, or you're doing ICU care on general floor patients. Wherever it is, it's very easy to bring the portable ultrasound right to the bedside. And then, of course, if you have an area where you have patients who have an infectious etiology and you're keeping all of those patients in a specific location, you could bring a point of care ultrasound there and you can leave the point of care ultrasound within that quarantined area. However, it is important to also know that ultrasound is a very cleanable device. We use ultrasound all the time. I think everybody who's watching this video is very familiar with the necessity of cleaning an ultrasound in between patients. That's even more pronounced when there is a medical crisis, and the medical crisis is due to an infectious etiology. So ultrasound, the probes can be disinfected. You have to look at the instructions for use, but there are specific ways, and the manufacturer gives you specific guidelines about how you should be doing that disinfection. Other aspects to think about are making sure that the cables are kept in an appropriate way, keep them off the floor, keep them out of the way so the cables themselves don't get exposed to an infectious agent. But once again, the cables can be cleaned. Another aspect of this is that the portable ultrasound can be used battery operated. So if you are bringing it to the bedside, or maybe you're bringing it to a makeshift area where you're caring for patients, for example, maybe you have to care for a patient in the hallway. Whatever the situation is, you can use the ultrasound under battery life, and therefore you don't have a need to plug it in. And there are some actually fairly long battery life of some of our ultrasounds. So I want to basically go down a little bit more into the nitty gritty and how ultrasound can be used in specific clinical evaluations. And I'm going to highlight pulmonary evaluation, cardiac evaluation, shock, and then line placement procedures in general. By no means does this mean that these are the only possible ways to utilize point of care ultrasound, but I think these are the ones that are going to be most germane in the present medical crisis and in a medical crisis in general. So that's where we're going to focus. You look at these and you look at the lung exam, the pulmonary exam, and some of the things we're going to talk about is identification of B-lines, whether B-lines is due to fluid overload in a patient who comes in with congestive heart failure, or a patient who develops B-lines because of overaggressive fluid resuscitation, or some of the new literature which is talking about identifying B-lines in patients with atypical pneumonias, including potentially the COVID-19 virus. We'll also talk about the utilization of ultrasound in the lung to identify more classic pneumonias. You'll be able to see consolidations. We'll talk about its utility to identify pneumothorax and pulmonary effusions. The cardiac uses of ultrasound are extremely important, and we're going to talk about this quite a bit within the discussion we have on shock. But overall ventricular function, being able to identify myocardial thickness, that's useful basically to get a little bit of an idea if somebody's had long-standing hypertension. Valvular function can be important because if you have a patient who has concomitant valvular disease, that could be confounding some of the treatments that you're giving, and it could also make that patient much more difficult to manage if they have another acute issue on top of it. And then, of course, pericardial effusion, and we'll talk about that both in the cardiac section, but also in the shock section. I'm going to talk about the shock section conceptually in the following way. The beginning part will be talking about how point-of-care ultrasound can be useful to identify potential etiologies. That etiology may be hemorrhagic shock. So, for example, a trauma victim who comes in with blood in their abdomen. It may be useful to talk about somebody who's in shock because of a pericardial infusion or who has a tension pneumothorax. It also be useful to differentiate for other causes of shock, potentially including, say, a pulmonary emboli, where you'll be able to look at the right ventricular function and maybe evaluate the patient for a deep venous thrombosis. For the present medical crisis, it's going to be extremely important to talk about the uses of point-of-care ultrasound to evaluate a patient who may be having septic shock. And in that case, the point-of-care ultrasound can be helpful as you manage that patient. One of the first things you need to do in a patient who has septic shock is make sure they have an appropriate level of preload. That is, that the pump is full, you have enough fluid, and you'll be able to fill the right side of the heart so it can then in turn fill the left side of the heart. And so looking at inferior vena cava index and evaluation of the inferior vena cava, as well as potential changes in cardiac output, looking at VTI after small fluid boluses, that'll be extremely important. And then the management will also include some estimate of the overall left ventricular function, including the estimates of the ejection fraction. As people probably know, early on in septic shock, you may have an hyperdynamic heart. And then later on in shock, that heart may actually not be functioning so well. And so it'll be useful to identify those. And then finally, if you have a patient who initially presents without any fluid in their lungs, and after aggressive fluid resuscitation starts to have a change in their respiratory status, it could be due to overaggressive fluid resuscitation, and that'll be useful to look at. And then finally, when you have an acutely ill patient, you will essentially always need intravenous access to manage that patient, whether that's from a peripheral line or a central line. And we'll talk about how you can use ultrasound to obtain IV access. So there are several transducer types. I think people watching the video here are probably familiar with that. You have a linear probe, which will be useful to look a little bit closer to the surface. That'll be useful for identifying things like a pneumothorax, but it'll also be useful to help start a peripheral line. You then have curved probes where you can look much deeper. That might be more useful for a fast exam. It may be useful for looking at other things within the lungs, for example, including looking for pneumonia. And then there's a sector probe, which may be able to go even deeper, may be useful in some clinical scenarios, although, of course, there are some differences in the aspects of the images that you'll be able to get from all of these different probes. So let's start our deeper dive here looking at the lung evaluation. The first slide talks about the lung segments. And the reason I bring this up is it's really important when you do the exam to do it in a systematic way so that you don't forget to look at something, and also that you do it in a way which will be reproducible, especially because you may be doing serial exams as you manage your patient over the course of time. And so identifying the different lung segments and having a tool which will help you walk through those lung segments is extremely useful. Here you can see a video of a patient who has B lines. This is an example of a patient who maybe came in acute respiratory distress due to congestive heart failure. There is some new data that shows that atypical pneumonia, specifically the coronavirus COVID-19, may actually have some B lines and may even have some confluence of B lines in what some people call a waterfall sign. So this is interesting to be able to do as part of your overall evaluation. And as I already mentioned, it's also very useful if you're doing continuity of care in a patient who has shock to see if maybe you've been a little overaggressive in the fluid resuscitation. So B lines being able to identify are important. And of course, if your patient comes in and they have fever and they're coughing and they have some shortness of breath and respiratory distress, doesn't mean they definitely have the new corona COVID-19 virus. They easily could just have a community-acquired pneumonia or another bacterial pneumonia. So being able to evaluate your patient for pneumonia is extremely important, and ultrasound has great utility for being able to do that. Ultrasound is also extremely sensitive to identify pneumothorax. This is going to be useful in a patient who has a pneumothorax for whatever cause. Maybe it's a patient who was intubated, requiring PEEP, and has, in the course of their therapy, developed a pneumothorax. But this can also be from many other etiologies. You can see here in the video that you see lung sliding, and then you see the area where there is no lung sliding and the point between that. Some people refer to that as the lung point. And by looking at this, not only can you identify that there is a pneumothorax, but looking at where you find the lung point may be able to give you an idea of how big the pneumothorax is. And that may help guide some of your therapeutic decisions. Specifically, do you need to put a chest tube in right away, or are there other therapeutic interventions that you may want to utilize? This is a video of a pleural effusion. Although pleural effusions can happen for many reasons, including as a complication for many bacterial pneumonias. You can see these in patients who have cancer, and there are many, many etiologies for it. But being able to identify a pleural effusion in a patient who may have that as an exacerbation of their shortness of breath, not only is it useful to know that they have the pleural effusion, but you would be able to use point of care ultrasound to guide your pleural tap, and that will be useful as you do your therapeutic intervention in a patient who maybe needs a pleural tap to improve their respiratory status. We're going to switch gears here a little bit and go into overall cardiac evaluation. I'm going to start by talking about just general ventricular function. Patients may come in with a depressed ventricular function for many reasons. They may have a cardiomyopathy. They may have had myocardial infarctions in the past. They may have a baseline decrease in their overall ejection fraction. But being able to assess their overall ventricular function is an extremely important part of the management of critically ill patients. And this is an extremely important part of the function of a patient who, for example, may be in septic shock. So here's another example of assessing ventricular function. And this is going to help manage patients and may help guide some therapeutic decision making, and important for you to have a reasonable idea of what their ventricular function is. There are other aspects of the cardiac evaluation which may be useful in certain patients. In this example, you can see here valvular disease, identifying their valvular disease and identifying exactly how significant that is, and maybe that is exacerbating some of your evaluation. And of course, it may be an important aspect in as you make your therapeutic decisions. So knowing what kind of significant valvular function dysfunction they have may be important. Maybe one of the most important aspects of using baseline point of care ultrasound in a patient who may be presenting an septic shock is evaluating shock as a whole. The way I think of shock is I always start by looking at what is the cause of shock. Now, if it's a patient who comes in febrile, you suspect that they're having septic shock, the clinical picture may guide you, but there are so many reasons that a patient may present in shock. And so, in general, a patient who comes in shock may require an E-FAST exam where you're going to look for some of the potential causes. So, let's discuss a little bit at a high level the possible causes. One of the possible causes, especially in a patient who presents with the appropriate clinical scenario, for example, a patient who comes in shock after having been in a motor vehicle accident, having hemorrhagic shock would be extremely suspicious. And being able to do a fast exam and looking for free fluid in the abdomen could be diagnostic and could lead you to recommending a very early surgical intervention for that patient. So being able to look for free fluid as part of the fast exam is an important part of the exam. You also may be interested in looking at a pleural effusion. Once again, maybe they have a pleural effusion of some other lung injury. And as well, if this is a trauma patient, maybe they have a pneumothorax. You'd be able to see that on your point of care ultrasound exam. This goes back to the cardiac exam, except in this case, you can see where I have a video here looking at a pericardial effusion. This could happen once again for many reasons. You could potentially see this in a trauma patient. You could see this in a patient with infectious etiologies. The reason it's important to identify this is there are therapeutic interventions, specifically a pericardial centesis, that you might consider extremely early if you have a patient who has shock, and a contributing factor to their shock is a pericardial effusion. Pneumothorax, we already discussed a little bit. You can see here the video again of a pneumothorax, and whether this is due to trauma, some other etiology, or it's a complication of the required ventilation for the patient. Having a pneumothorax and appropriately intervening can be life-saving for your patients. If you look at the next one, where we're able to do an exam to look for a deep venous thrombosis in a patient with an appropriate clinical presentation, knowing they have a deep venous thrombosis and knowing that they have some changes in their right ventricular function may lead you to a much higher suspicion of the patient having a pulmonary emboli, and that may help you guide their management, whether it be whether they need another test or whether you feel that they need immediate intervention. Once you understand or think you understand the etiology of the patient's shock, obviously the next step is to try and manage them. I always think about shock as, do you have appropriate preload? So have you filled up the patient's right side of their heart? You've given them appropriate preload so that that can be sent to the left side of the heart, et cetera, et cetera. So the first step is to look at that preload. There are two ways that you'll be able to utilize point-of-care ultrasound to do that. One is by looking at the inferior vena cava, and you can see here a video of the collapsibility of the inferior vena cava. That will give you an idea of is the patient appropriately preloaded. And then if you look at the cardiac output, and you can look at the cardiac output, and I think I have this on the next slide, you can trend the VTI of the patient and give them small fluid boluses, and you can see if you get a positive response to those small fluid boluses. And once again, that's a good way for you to ascertain that this is a patient who may still be fluid responsive, and maybe you need to be tanking them up, that is, giving them a little bit more preload. Once you have that done, you then would need to ascertain how is their overall ejection fraction. We've already discussed this in the cardiac video, that you'd like to take a look and see how well is their heart pumping, and maybe get an estimate of what is their ejection fraction. And then finally, it is possible that a patient who came in without having significant fluid in their lungs develops fluid in their lungs because of overaggressive fluid resuscitation. And so once again, looking for B lines in a patient who is starting to have some respiratory issues after you've resuscitated them for shock, that could be extremely useful. Last but not least, you're going to need intravenous access if you're going to effectively manage your patients. And there's two different ways that point-of-care ultrasound can be useful in doing that. One is by helping you start a peripheral line. And then, of course, you may need to start a central line. And once again, point-of-care ultrasound can be extremely beneficial for starting a central line. So in summary, there are many, many potential benefits for point-of-care ultrasound. You can see here that there are guidelines and other references. These are just a couple of them. You can look at the first one, and it is an article that talks about applications of being able to manage your patients' their cardiopulmonary status, and doing that utilizing ultrasound to assess their hemodynamic response. There's another reference here which talks about the initial modality for disaster care. That's a little bit of a different situation here, but you may find yourself in a situation if you're, for example, using a makeshift emergency department where you might not have access to any other imaging modality, and maybe the very first thing you're going to be able to do, or the only imaging you'll be able to do, is with point-of-care ultrasound. There's a bunch of other examples here talking about how ultrasound is useful in general to identify potential causes of shortness of breath in a patient. There's another example here where it talks about ultrasound and the benefits that it can have in the emergency setting to be able to figure out what's going on with the patient who maybe presents with potential heart failure. Again, a couple of other references. I believe you'll have access to these so you can go through them, so I won't go through these in so much detail. But the point is that there are many, many potential benefits of utilizing ultrasound in the acute care setting, whether that be the emergency department, the ICU, or in many other potential settings, and being able to do ultrasound. So going to the last slide here, looking at the benefits of ultrasound, the fact that it is portable, the fact that you can bring it right to the patient. You do not need to bring the patient to the imaging, since you can bring the imaging to the patient. In a case where there's a potential for infectious etiology, ultrasound is cleanable. It can be disinfected. Many, many potential benefits to using ultrasound. We discussed in a little bit of detail the pulmonary benefits, the cardiac benefits, the benefit in shock, and the benefit for being able to obtain intravenous access. But of course, there are many, many other benefits for this. And then for your information, if you want to do some further reading, there are some references and some guidelines referred in here. Thank you.